Back to
Yes,
Mangalore.
yes. Yes, ma'am. Yesterday late night.
So I think the
Well,
discussion, yeah, you can go ahead.
yes, ma'am. Please tell, ma'am.
It's being live streamed actually. I think Dr. Neeraj has opened it, I think.
Okay.
Hello, good evening. I think Dr. Sinchana, you can start now.
Okay. Okay. Uh, Good evening, everyone. I welcome you all to the yet another case discussion platform. This one session on Allergy Forum. This is basically a platform by the Allergy chapter, wherein we discuss cases of related to allergy every second Tuesday of every month. And this is the seventh episode, and we are very happy that we are able to do this under the able leadership of Dr. Neeraj Gupta. Sir, today we have very interesting discussion on food allergy. And to present this, we have Dr. Vaidehi Hardas with us. She is a consultant pediatrician, allergy specialist, and a lactation consultant at Mumbai. She is done her diploma in allergy and asthma from CMC Vellore and a fellowship in allergy asthma from Medtrain as well. So she has her own clinic and visits various hospitals such as Surya Hospital and Jyoti Hospital in Mumbai. And she was very kind enough to accept our invitation to present the cases related to food allergy, which she has seen in her own practice. And to moderate the session, we have Dr. Soumya Nagarajan with us. Madam needs no introduction. Actually, she is a very well-known name in field of allergy. And as a formality, I would like to introduce her. Madam is a consultant pediatrician, allergist, and an immunologist who is practicing at Sanjeevani Specialist Clinic and Motherhood Hospitals, Bangalore. She's a
Thank you.
very well-known academician and a researcher. She has done a lot of research in the field of food allergy and even drug allergy. And actually, she's one of the pioneers who has done food immunotherapy, in fact, oral immunotherapy in India.
Yeah.
And we are very glad to have ma'am as an expert today for this very important session. As we all know that food allergy is a very common condition which we come across, and lot of mislabeling or probably false diagnosis also happens sometimes. And to avoid all this, we if we discuss such cases, it is very important in our day-to-day practice. I welcome you, Soumya ma'am and Dr. Vaidehi, and over to you all.
Thank you, Dr. Sinchana, for a very kind introduction of myself and Dr. Vaidehi. And I would like to thank IAP Allergy and Applied Immunology chapter under the able leadership of Dr. Neeraj Gupta for taking this initiative and continuing it on a consistent basis. And thank you for giving us this opportunity. So without further ado, I think I would invite Dr. Vaidehi to start the case presentation. We would take the questions along with the case presentation, Dr. Vaidehi. Okay?
Okay, ma'am. Okay. Thank you so much, IAP Allergy chapter, for inviting me to present the case on food allergy. I shall share my presentation. Is it visible, ma'am?
Yeah, the slides are visible. Kindly go on to the slideshow.
Yeah. Slideshow is visible.
Visible.
Is it
Yeah,
visible? Yeah.
it's visible and you're audible. Please go ahead.
Okay, okay. So here we have the 2.5-year-old. So this girl who presented to me at the age of 2.5 years, she was second by birth order, born of non-consanguineous marriage. Birth-wise, there were no complications. Developmentally, absolutely normal child. And first 6 months of her life were absolutely normal. She was exclusively breastfed, and there were no illness or no as such no complaints. But at the age of 6 months, the mother noticed that when she started giving lactogen, basically it was a cow milk based formula, which she started giving to the child within the quantity of the milk was around half a katori, and within 5 minutes to 10 minutes of consumption of this milk, the child appeared to have hives, flushing of face, swelling of lips, eyes, coughing, and rhinorrhea. The mother was very clear. The onset of symptoms was immediately within 5 to 10 minutes of exposure. She was taken to a nearby pediatric clinic and she was given first generation antihistamines, but that time the symptoms were mild and they settled, so she did not require admission and she was sent back home. After 1 week, because it was something unusual, the mother did not give lactogen. She initially thought that it was some problem with the formula. So she tried giving actual whole cow milk, same quantity, half katori milk, after 1 week of the first episode. So after consumption of this much amount, child went to sleep, and after 1 hour, she woke up with vomiting, coughing, wheezing, and slight urticarial rash on her body. Again, in the she was taken to nearby pediatric clinic, because this time she had wheezing. She was given aspirin nebulization and antihistamines were given, but no intravenous or intramuscular injections were given at that time. The child recovered and sent back home. So these were the two distinct episodes. The mother clearly remembers them, and after this, she suspected that there is something wrong with the child. Probably she is allergic to cow milk, so she started avoiding cow milk as well as lactogen formula milk.
So, Dr. Dehi,
Within
before we go on to the first, after this episode, can you go back to the previous slide, please?
yes.
So the child was full-term born, and the child was exclusively breastfed, and the child had never received any formula even during the initial sometime when the child needed oxygen, and after that also, right?
Yeah. She did not require a formula. That was very
Okay.
clear. Yeah.
Yeah. So
Yeah.
even when the
Yeah.
child was on exclusive breastfeeding, was the mother continuing to take milk and milk products in her diet?
Yeah, she was taking milk and milk products in her diet. And
Okay.
and if we see, I mean, if we think of atopic marks, the child in her early life, like around 1 month, 2 months of age, did not exhibit any signs of eczema or any
Okay.
atopic dermatitis.
Yeah, that is a very important history, as you rightly pointed. Can you go to the next slide, please?
Yes.
And
Yeah.
until the child was 6 months, was the child gaining weight adequately and
Yeah.
without any other developmental milestone being delayed? Nothing.
Yes, ma'am.
Why?
Nothing development wise till now also she is not delayed,
Okay.
but of late she is not gaining weight, ma'am. Actually, since
Okay.
the age of around 2.5 years, I have been in, she has been in follow-up with me. Now she's 3.5 years old. So since
Okay.
1 year, the weight has been, she's gaining very slowly.
Yeah. Why do we think, sorry, my Zoom has not able to detect my camera. Somehow the camera has gone off. But Dr. Vaidya, why do you think they any concerns about weight? Would you give some idea regarding some issues which is happening with the gut? The child is not tolerating something the child is being given, correct? So I
Yeah.
think in early life, especially when sometimes the child is thriving well, and if they have other gastrointestinal manifestation, that could also be another spectrum of probable concerns of food allergies. Or if the child is not gaining weight adequately and exclusive breastfeeding also, we must have that concerns of something probably related to the child is being given through by mouth, correct?
Yeah.
So when you tell me the presentation that at 6 months when the child was shifted to a cow milk based formula, and the child had reactions within few minutes and of having this formula, and also the child responded well to an antihistamine, oral antihistamine, and on subsequent exposure, next slide, Dr. Vaidehi, where the child required again exposure to cow's milk and also had reaction very similarly to the first episode within few hours.
Yes, ma'am.
This time it was a little more severe involvement rather than just cutaneous manifestations. The child also had gastrointestinal manifestations, and the child will had a wheezing episode also. What does this presentation give you an idea? What kind of, is it a food adverse reaction? And if yes, what kind of food adverse reaction did this child have?
So looking at this history, since the child developed these reactions within 1 hour of consumption of cow milk protein, uh, uh, so uh, uh, and also it is involving the skin, the
Correct.
gastrointestinal tract and the respiratory tract together. This sounds like a immunological reaction where we have involvement of specific IgE to a food protein.
Okay.
And this fits into the category of anaphylaxis because there are two systems along with cutaneous. Either we need to have respiratory or gastrointestinal involvement. So this fits into the category of anaphylaxis as well. And there is twice before 1 week also and this episode also, there is typical temporal association between the exposure to cow milk and appearance of manifestations within few minutes to 1 hour. So that more goes towards immunological reactions and IgE mediated reactions more so.
Correct.
IgE mediated cow milk. Yeah.
Correct. So you are right in saying that uh, when we are talking about possible food reactions, we broadly classify the term as adverse food reactions, and we classify them further as immunological mediated or a non-immunological mediated. For us, the time is of essence when we are talking about immunologically mediated reactions, which could be IgE mediated, which is a very immediate reaction, and a non-IgE mediated or a mixed disorder. For us, in IgE mediated reactions, the temporal correlation of the food exposure and the onset of symptoms, which could be within few minutes to maximum of about 2 hours, is of essence when we are talking about immediate reactions, which the child definitely fits on to subsequent exposures on different episodes to cow's milk protein. And the child responded well to antihistamines, correct? Because it is an
Yeah.
IgE mediated reaction. As you rightly said, this child could be having gastrointestinal manifestations, wheezing, and a slight urticarial rash. Though there was no documented other systemic involvement and she responded well to antihistamines, I'm still not whether sure we can definitely classify this exactly as anaphylaxis, but what you have presented the presenting symptoms, yes, two system involvement could be a possible anaphylaxis.
Okay.
So, what is the most commonest food you think could be the presentation in the first year of life in our Indian context for IgE mediated food allergic reactions?
So in first year of life, ma'am, cow milk is the most common one, most commonly encountered food allergy in infants,
Yes,
followed by egg. These two are very common in Indian population.
correct. I think by far the cow's milk protein allergy is by far the most commonest um, food allergic reaction, immediate type or non-IgE mediated, but most commonly the immediate IgE mediated reactions, which is the topmost commonest food allergen we see. And uh, what is the other commonest presentations, Dr. Vaidehi? In say this child definitely had IgE mediated reactions because it definitely fits within few minutes to about 2 hours after the consumption of the food. So reproducibly, which can occur on different occasions. What are the other presentations of an immunologically mediated food allergic reactions which can happen?
So when we have immunologically mediated, we can have IgE mediated ones, which our this patient has, and
Correct.
also when there is no involvement of IgE, no non-IgE mediated reactions, we call them as non-IgE mediated reactions. They can also present, and cow milk is the most common food allergen which presents in this manner,
Mm-hmm.
and where we have most of them being gastrointestinal in in nature, like diarrhea or vomiting
Okay.
and yeah, uh, constipation. So
Correct.
non-IgE mediated reactions are very common with cow milk protein as well.
Yes, the other spectrum of non-IgE mediated could be food protein
Mixed
induced.
ones.
Yeah, mixed ones could be atopic dermatitis or eosinophilic gastrointestinal disorders. Non-IgE mediated, we may have a spectrum of allergic proctocolitis, where it is a well-thriving child and can only present with blood in stools upon exposure. And if we remove that
Yes, ma'am.
incriminating allergen for the particular from the child's diet, the child will be all right. On the other end, we have something called food protein induced enterocolitis syndrome, correct? Which could be an acute presentation or a chronic presentation. And acute presentation could be more in the terms of our viral gastroenteritis presentation, where the child could just present with recurrent vomiting, diarrhea, leading on to volume loss and presenting with dehydration to the emergency, where remarkably the infective workup could be absolutely normal, but on subsequent high index of suspicion, if we are trying to eliminate that probably milk in most of the children in infancy, or other solid foods which could be rice, soy, wheat, among others, I think they recover. On the other hand, chronic FPIs could be failure to thrive, nutritional deficiencies they could present. So I think that's how we differentiate between the presenting symptom. That is why clinical history is of utmost importance when we are thinking about classifying them into an immediate reaction or a IgE mediated reactions, because deciding on our differential diagnosis, we can choose whether further supportive diagnostic tests would be of some help or not. Yes, Dr. Vaidya, please go ahead.
Yeah. So then gradually she stopped cow milk, but she tried with other milk products like paneer, curd, and butter, and she noticed similar kind of reactions after these food items as well. However, with ghee, she did not notice any such symptoms. By then, she was almost aware that this could be some cow milk. Milk related allergy, so she didn't try with other cookies, cakes, and sweets because they mostly contains milk protein, so that's why they were avoided. But at the age of 1 year, she remembers she had introduced Parle-G biscuits, and surprisingly, the child did not react to that. So she was giving for a couple of months, but on her doctor's advice, she had stopped. Again, at the after one gap of 1.5 years, she reintroduced Parle-G biscuits, and then she developed reaction after that encounter. At present, at around 2.5 years of age, when we encountered her first, she was able to tolerate Oreo biscuits. And the family is purely vegetarian. So, in veg food items, if we consider highly allergenic food like peanuts or tree nuts and other dals and wheat, she is able to tolerate all of them. She doesn't develop any of the symptoms of food, I mean, allergy to
Okay.
these other allergenic proteins.
Yeah, so from 6 months to 1 year, interesting. So when at that point, was the mother not advised, or anybody, she was advised to stop milk and milk products? And she thought only it was milk, but she had continued to introduce milk containing other dairy products with reproducibility of symptoms, which is very
Yes.
consistent with our probable differential of this cow's milk protein allergy, because the history is very straightforward. However, ghee, why do you think the patient had taken ghee without any symptoms, Dr. Vaidya?
Because in ghee, ma'am, it goes through a lot of processing, and when we have ghee, we mostly have a fat content is more compared to the protein. So, because of high processing, the protein structure that is present in milk is altered.
Okay.
And as we know, because of heating and baking and processing, the allergenic epitopes are altered and they lose their allergenicity. So maybe that is the reason why ghee was tolerated by the patient.
You have rightly pointed that whenever we are talking the context of food allergies, the protein content in the food is the actual culprit. And only, I think, except in one particular food allergy called alpha-gal allergy, where the carbohydrate moiety is the actual allergenic culprit. Most of the other food allergies, the protein content of the food is the causative uh, culprit for causing the spectrum of food allergy symptoms. So ghee per se, the protein content of the food is, the milk is very negligible, and most of our patients, especially when we are starting with the introduction, graded introduction after evaluation after a certain age, we would think about ghee also very initially first. And Very interesting to know that the biscuits, Parle-G biscuits, what you have mentioned, it has a high amount of milk solids. Where she was developing, she was tolerating it earlier. On stopping and reintroduction, she had developed reaction to
Reaction.
this particular food. So, what is the natural history of the cow's milk protein allergy, Dr. Vaidehi?
Ma'am, cow milk protein allergy, mostly around 70 to 80% of the infants who are allergic to cow milk protein will outgrow by the age of 5 to 6 years. So
Okay.
cow milk is well known to outgrow, but again it depends on what kind of protein the child is sensitized to, and the component of cow milk protein. That will also determine whether the child will likely outgrow the milk protein allergy or not. But mostly natural history, if we consider, by around 5 to 6 years of age, 70 to 80% of the children will outgrow milk protein allergy, IgE mediated.
Uh,
And also, if we keep, if they tolerate baked, if the baked milk products are there in the child's diet, and continuous exposure to baked milk products in the diet will also help the child to tolerate milk and
yes. Yes. So
raw
we'll come
milk
to
and yeah.
Yes, we'll come to that because that's also one of the important reasons, in spite of the child having a sensitization pattern on the skin prick test or a serum specific IG, we can still continue to introduce milk in some products. We'll just come to that in the management. Now, for the discussion's sake, along with milk and egg, you did mention very rightly that the two are the topmost common causes of food allergies in infancy. But in children under 5 years of age, which are the other common allergenic foods you think we can encounter?
Apart from milk and egg, we can also have allergy to wheat and soy protein.
Soy protein.
Fish and shellfish, shellfish, peanuts are also very common culprits of like highly allergenic food.
Dr.
Yeah, but
Neeraj? Yeah.
mostly, yeah, four of them, like wheat, milk, soy, and egg they are the topmost ones.
Yes.
But we can
And
also
along
have
with peanut, yeah, we can also have for wheat, peanut and tree nuts to a very lesser extent. But as you rightly said, milk, egg, wheat, soy, these are the most commonest causes. Dr. Neeraj has a very interesting questions. Can IG mediated milk protein allergy be the cause of failure to thrive or poor weight gain? What do you think?
Could be, ma'am, could be a cause of failure to gain weight, and also it depends on, if the child also has other comorbidities like allergic comorbidities,
Yes.
like asthma, and those things are also not controlled, and child is getting repeated episodes of wheezing and going through the illnesses, that also contributes to the malnutrition part. Not gaining weight
So
could also be attributed.
that could be a comorbid factor, but in food allergies, as you rightly said, we see this more of in the non-IgE spectrum, where the child IgE mediated food allergies could be there on the severe spectrum, but more commonly we see in the non-IgE mediated spectrum also, where especially chronic FPIs uh, could
Failure
be
to thrive.
yes, presenting with failure to gain weight or chronic weight loss or stagnation could be there. The other important question uh, we get to ask, and also Dr. Neeraj is also pointing towards that. In a proven case of milk protein allergy in an infant, the mother commonly asks, should we stop breastfeeding? And and is it easier said than done to stop the milk products, dairy and dairy products from the mother's diet? Do you think there are any specific indications where we can tell the mother safely to stop dairy and dairy products in one's diet?
Ma'am, in case of non-IgE mediated, it holds true. It's like a diagnostic elimination that we do for non-IgE mediated. But for IgE mediated, if the child is not developing symptoms being on breastfeeding, then I don't think we can continue to, because whatever amount or in whatever form the milk protein is getting into the child's body, but the
Yes.
child is not developing symptoms, then we should continue to do that. That is
Yeah.
what
So
the
contrary to, yeah,
principle
you're
is.
right. You're right. Contrary to the earlier recommendations where strict avoidance remained the norm, I think as we have gained more insights into the management of the cow's milk protein allergy, before where we used to see complete elimination of milk and milk products from the mother's diet was very controversial, and where the other alternatives could be extensively hydrolyzed formulas or an amino acid formula, which is very expensive and also not routinely easily available. I think we definitely encourage the mother to continue breastfeeding and uh, to continue the consumption of dairy products in her diet. There are specific indications where the mother has to stop milk products, especially if there is failure to gain weight and the severe spectrum of the cow's milk protein allergy, and if there is hypoalbuminemia. So I think this was very nicely highlighted in one of the Delphi consensus paper on cow's milk protein allergy, of which Dr. Neeraj Gupta is also one of the co-authors, where there is emphasis even by the Indian Academy of Pediatrics also to continue breastfeeding even if the child has a proven cow's milk protein allergy, unless we have the specific indications. So the
Okay.
other common question, say if it is only breast milk, if it's only cow's milk, which is the problem positive factor, um, the mother shift to the other other sources of milk, or if the child is on the weaning and solid foods, if we are telling them to stop cow's milk and its products from the diet, can buffalo milk or other animal sources of milk can be given? This is a common question also being asked by our patients in clinical
Patients.
practice. So what
So,
would
ma'am,
you think,
actually,
Dr. Vaidehi?
There we have to think about the cross reactivity when we are answering this question. So in between, like considering other animal milk like your goat or sheep, there is almost 90% cross reactivity is there between cow's milk, goat milk, sheep milk, and also considerable reactivity between buffalo milk as well. So if we but we consider camel's milk or mare's milk, there is hardly any cross reactivity. In case of mare's milk, it is just 4% cross reactivity. So that can still be safe. But recommending other animals like sheep or goat milk, I would not recommend, because there is a high degree of cross reactivity between cow milk and the sheep milk, goat and sheep milk.
So generally, I think um, in patients, definitely, I mean, we tell that all mammalian milk, because of the high degree of cross-reactivity, as you rightly said, we would be avoiding all cow's milk or other mammalian milk also in this patient. So another interesting question is, in a case of proven or suspected milk protein allergy in a baby under 6 months of age, what are the alternatives, especially if the breast milk and hydrolyzed formulas are not available?
Then we have to shift to, ma'am, we can see if the child tolerates soy milk. If it is IG mediated, ma'am, in non-IG, there is still,
No.
we can still have 30 to
No,
40%
soya
of
milk
the patients.
definitely is contraindicated in children less than 6 months of age. Correct? So because it is not proven safe and there are concerns about some dysregulation of few systemic functions which can occur through the introduction of soya milk, which is hypothetical. But generally, even the guidelines, IP guidelines also strictly do not recommend introduction of soy-based formula under the age of 6 months. Okay. And above 6 months, if we are telling also, we must make sure that there is no co-sensitization with with soy,
Uh,
because 1/3 of our patients with cow's milk protein allergy would have
Co-sensitive.
co-sensitization with milk because of, again, structural cross-reactivity. And if you are asking the mother to stop the milk and milk products with continuation of breastfeeding in her diet, what is the one uh, thing you have to recommend for the mother?
Vitamin D and calcium she has to,
Calcium. Yeah,
calcium,
because we are anyway removing
deficient.
the calcium from her diet. I think it is always important for us to emphasize that the mother is given on a prescription of the calcium supplements until she continues breastfeeding. Can you go to the next slide, please?
Yes, yes. Coming, considering her other comorbidities, from this period of 6 months to 1 year, she also started having certain nasal symptoms like allergic rhinitis, where she would start sneezing and continuous watery rhinorrhea, along with few episodes of wheezing requiring nebulizations. The symptom frequency of these symptoms actually increased in frequency and severity gradually until from the age of 1 year to 2.5 years. There were 3 admissions also for severe wheezing, and always the child would respond nicely to the saline nebulization. After saline nebulization, the child would settle quickly. So this was mother's observation. And also for this, means for her nasal and chest symptoms, there were no as such diurnal triggers. There was no specific diurnal variation. The symptoms would get triggered indoor as well as in outdoor environment. And mainly the mother had noticed that on exposure to cold air or any cold food or weather change, she would get nasal symptoms, and within a span of few hours to a day, she would go on to have florid wheezing and fast breathing as well. They don't have any pets in the family. There is no history of passive exposure to passive smoking or any kind of indoor air pollutant being present at home. So these were the things that started coming later on from the age of 1 year, and then she progressed chest wise and nasal allergies that progressed to a very severe level by the age of in the span of 1.5 years.
Okay. Can you go back to the previous slide, Dr. Vaidehi, please?
Hmm.
Yeah. So what do we understand by atopic march?
Atopic march, which is also known as allergic march. So
Okay.
the child having tendency to have allergies or with a background of atopy progresses through various stages. So first in the atopic march, we can see atopic dermatitis, which usually comes in the early infancy, followed by food allergy, then either wheezing or asthma and allergic rhinitis. The sequence may not be same, and each individual may not have all of them at one point of life. At one point of time, one thing will be more prominent, and then later on the other things keep
Correct.
coming. So that is how the person having allergic tendencies or having atopic background can progress to the through this stages of atopic march.
So, say, for example, as you rightly said, the atopic march is a probably a sequential progression of an atopic disorder, though it may not happen sequentially in the order you rightly said, but most commonest presentation could be in the form of presentation of atopic dermatitis and coexistence of food allergies and later progression to respiratory allergies. There is also something called reverse atopic march, where we may see the onset of atopic symptoms probably a little later in life and may not follow the conventional atopic march. For us, especially in the background of food allergies, which is one other atopic comorbidity which is of significance.
Having eczema, atopic eczema is a single most important risk factor in the background of food allergy, because when we consider allergy, before allergy develops, we need to have sensitization, and skin is supposed to be the most immunogenic. Skin, the sensitization in eczematous children, because the skin being porous, happens to the skin, and that causes severe sensitization, and then later on they develop significant allergies. So having skin eczema is important risk factor in the background of food allergy.
Food allergy. That is true. Somebody who has atopic dermatitis, severe spectrum, moderate to severe atopic dermatitis, they may have a food sensitization. But when there is a food allergy, I think somebody who has an background of asthma is a
Asthma,
major risk factor for us, because coexisting asthma and if the asthma is not very well controlled, the respiratory symptoms, the chances that that particular individual can have a very severe presentation in the form of anaphylaxis
presentation.
also is more. So whenever we have a patient with asthma, always ask for food allergy and make sure. And if the patient has food allergy, we always look for coexisting respiratory symptoms, low respiratory symptoms, and appropriately control them and keep it under very good control
Control.
with good pharmacotherapy. So that is one thing we must always make sure the patient is well controlled. And we were also talking about the how much of the bovine milk can be passed on through the breast milk. So this is answer from Dr. Neeraj. And so as he has rightly pointed, the human breast milk is synthesized from mammary glands, which are mainly the source of nutrients from the mother's own blood. It's not a direct transfer of animal milk. And if the mother is consuming cow's milk or other dairy product, the chances that there are few proteins from the bovine milk, such as casein or something, which can be passed on to the breast milk in minute quantities, and which are very negligible. So which are not by itself enough to elicit an allergic response. So generally that also forms the basis why we do not advocate the stoppage of dairy and dairy products in mother's milk. Okay. Can you just
Okay.
go on to the next slide, Dr. Vaidehi?
These were the triggers that I
Yes.
tried to identify
Sure.
for her nasal symptoms and chest symptoms. But they were only typical change of weather, cold air would trigger her nasal symptoms, and then she would progress to wheezing and then fast breathing.
Sure.
Yeah.
Next slide.
So yeah. So initially, while taking history, the mother was repeatedly telling that apart from this, also when they would cook some dishes at home containing milk or just boiling of milk, also the child that time also the child would start having sneezing and then coughing and wheezing. And also when they used to dine out in the restaurants, they noticed that even though the child would not consume any of the outside food items, they would notice some symptoms of her nasal and chest symptoms being triggered by these things. So that is
Okay.
something that that is something unusual here.
Yeah.
In the history.
Yes. So why do you think, I mean, even say, I think it's very consistent that the child is being on, even on accidental exposure when they were cooking at home, or if somebody has been exposed to milk products, and if they have come and touched the child, my child may have developed hives. I think that's also a subtle trigger that, I mean, a hint that the child is still sensitized to milk. And we see this very commonly also.
Okay. So they are here the two thoughts, like is it is it really triggering her symptoms, or is she also developing sensitivities because she is having predominant nasal and chest symptoms? So is she also developing sensitization and clinical allergies to other indoor allergens was also one of the thought, because she was progressing very rapidly on her chest and nasal allergies, that part.
Okay.
So,
Okay.
yeah.
Definitely. I think your thought process is definitely right. We have seen patients, especially when you're outside and they may not have eaten actually, even on the areas where the food is exposed, especially in common food courts, or especially where the children go out. And it was not uncommon for us to encounter also that the child would have developed some cutaneous manifestations, mainly if they are sensitized to that particular food. It is also common that, as you rightly said, there may be some other weather change or cold air, which could be mainly, maybe, I think it may be vasomotor rhinitis, where we see that temperature variations can also cause the nasal symptoms. Though it's a little uncommon in this age group, where at 1 year, probably this could be a little more in the older age group, I would see. But as you rightly said, it could be the sensitization for her respiratory symptoms also we could be seeing. So in the context of this child having possibly thinking about IgE mediated cow's milk protein allergy, did you think of any, how did you manage this child going forward?
So because initially, ma'am, for when she was in trying other food products, that time skin manifestations were prominent. But later on, she was having predominantly nasal and chest symptoms. So definitely, this was looking like an asthma. She was going on ahead on the atopic march. So
Okay.
considering asthma as one of the comorbidities, and we need to keep that under control. I started her on inhaled low dose corticosteroids to stabilize her chest symptoms because they were very frequent. And as we discussed, that there is a high risk of having then food triggering allergic reaction and that going into anaphylaxis, the chances are very high. So that was the first thing that had to be controlled in this patient.
Okay.
And also, if it is anaphylaxis, then also to make her, the symptoms, how to identify that she is having anaphylaxis, the symptoms were taught to her, and she was also given adrenaline injections. Two injections were given to the mother, and she was taught how to inject that into the thigh of the child when she develops, when she suspects these symptoms are developing. So these
Yeah.
are the
So
main thing that she needs to
sure.
understand.
How would you confirm your diagnosis? That clinically, though, I think it is very evident. So the mother would ask how long, we would tell them to continue avoiding milk products in a child. So how long you would want to continue, or how would you corroborate it? Would you want to do any supporting tests for this child?
Yes, ma'am. So this sounds like on history, this sounds like IgE mediated food allergy. So after stabilizing her asthma and wheezing part, then the child was subjected to skin test and blood test were done. Because we can do specific IgE either by doing blood test or we can do a skin test to see whether the results are correlating with the history that the mother is giving. So
Correct.
it was done, and ma'am, one interesting history actually was left
Okay.
in her vaccination record. Actually, she has completed like as per IAP schedule, but during her second dose of MMR at around 15 months of age, again after the dose administration, within 5 minutes she started having these symptoms: flushing of face, coughing, choking, watery eyes. And that time she was given injection adrenaline, aspirin nebulization. She settled within 30 minutes. And again, same reaction happened in the second dose of, second year of influenza vaccination, not during the first year. So is it related? Means these vaccines could contain egg products, traces of egg, maybe. But how is this related to milk allergy? Or, that was very, very astonishing.
So the second dose of MMR was within 5 minutes, and flushing, choking, injection adrenaline, she did settle. Again, it is important that we may think about a possible um, anaphylaxis to any of the component of the vaccine. And was the reaction similar to the second dose of MMR also when she received the influenza vaccine in the second year? Was it also the
This
severe
second.
spectrum, or
No, the influenza was not severe, not like MMR. It was mild. She developed some urticarial rashes, and that's it.
okay?
Mm.
I think there has been many studies which has been corroborated that children who have proven egg allergy, and the concerns that these vaccines are grown in egg-based chips, where the cultivation can be a causative factor in the egg-based media. I think the concerns are very unfounded, and even with children who have had proven egg protein allergy, it has been found to have given flu vaccine and MMR vaccine very safely. If the child has to receive the further doses of influenza or MMR, again, I'm not sure what was the exact cause during the second dose of MMR. Is it just a vasovagal attack, or we would have to give graded uh, introduction of the MMR vaccine under close monitoring, which would be a more logical way forward, even if the child has to receive the booster dose subsequently. So I feel there are unfounded concerns regarding the vaccinations of influenza or MMR, even in children with proven egg protein
Egg allergy.
allergy. Yeah,
Okay. Okay.
we can go
Uh,
for.
Yeah, so family history wise, she had a very strong background. Mother, elder sibling suffering from allergic rhinitis, first cousin asthmatic, and paternal grandfather has eczema. Um, and
Okay.
diagnosis wise, based on history, she has IgE mediated symptoms with cow milk protein allergy, allergic rhinitis, and asthma. Examination on examination, apart from chest finding of V's
Okay.
and malnutrition on anthropometry, the otherwise everything was fine. Nose and skin, everything was fine for this child.
Okay.
Yeah.
So there was good weight gain, correct? And there was no failure to gain weight, and she was thriving well.
Till was 6 months to 1 year, she was thriving well, but in this 1 year, she has not gained weight. Again, now
Okay.
also she has some. At the age of 3.5 years, she is just 9.9 kg. Consistently, the weight revolves
Okay.
around the same value.
Okay. How did you proceed with the investigations, Dr. Vaibhav?
So investigation wise, ma'am, SPT for milk was 4 by 5 initially at the age of 2.5 years with good negative and positive control. Total IgE was 143. Her specific IgE to cow milk was positive, and she had, considering her
Okay.
CRD report,
No,
she
no, no, no.
was.
Just go back to the previous slide, Dr. Vaidya.
Yeah,
Sorry,
sorry, sorry.
previous slide. Yeah.
Yeah, yeah, yeah.
So I would like to draw your attention that total IgE for us in the management of allergic disorders would be of very minimal help, correct? Because
Yes,
there
yes,
is total IgE would be raised in many of the other conditions
other
such as
conditions.
parasitic infections, other comorbid conditions. So it is very non-specific. It is not limited to only allergic diseases. So I think except
Correct.
in probably few of the conditions where I may think about using a anti-IgE or to see whether response may be good or not. Other than that, I think it has very limited value for us in the workup of any allergic diseases. I think you may have just put it up because if you would
To
have
highlight it.
if you would have done a component testing, as you rightly said, if the total IgE was mentioned there, you may have put up because of that. But just for
Yeah.
the benefit of our discussion, academic discussion, IgE has very limited value. So
Yes.
there are certain cutoff values, Dr. Vaidehi.
Hmm.
Even in the recent one of the meta-analysis systematic review, which was published in 2023, where they have given a cutoff values for milk in the skin prick test or serum specific IgE less than 2 years or more than 2 years, where if it is less than uh, it's around 5 millimeter in children less than 2 years. And if it is more than 7 to 8 above 2 years of age, it shows that 95% predictive value, even if you do a oral food challenge for the diagnosis of food allergies, the child would react. So
Hmm.
we are very safe in telling them to still continue avoiding if
Cow
the
milk. Hmm.
yes, milk and milk products in their diet, if it is around these ranges. Can I understand why a serum specific IgE blood test was done for this child?
Yes, ma'am. Actually, as you said that there are specific cutoffs related to particular food items. So that's why specific IgE when we do, uh, if for the milk it is more than 15,
Mm-hmm.
after the age of 2 years, and below the age of 2 years if it is more than 5. These are the cutoffs for specific IgE. So if the value is beyond these cutoffs, then there is high chance that the child is going to react to the when the child encounters the milk, there is high probability that the child is going to react to that food challenge. But that doesn't tell us about the severity of the reaction that the child would develop. Suppose if it is too high, well beyond cutoff and very high level, that doesn't tell us that the child is going to have severe symptoms. It just
Correct.
tells that there is high chance that the child is going to react to the encounter.
Correct. Well, probably react on exposure to that particular food. So generally, even the higher the number, even on the skin prick test or on the serum specific IG in the context of food allergy, is not directly proportional to the severity of the symptoms, though it can give us a probability about the reaction occurring on exposure to that particular foods. So I think generally we have to interpret with caution, again with a good clinical second history. And probably serum specific IgE may need not be done for all patients when we are doing skin prick test alone, especially if they have atopic dermatitis or if the patient is on antihistamines, where we couldn't have done an skin prick test at the first initial follow-up. I think there are specific indications where we could do a serum specific IG. Either are equally good. Okay, so you did proceed to do a component testing in this child. What are the possible specific indications? Go ahead, Dr. Vaidehi, to the next slide.
Yes.
Okay.
So,
Yeah.
So alpha-lactalbumin and lactoglobulin, which are also the components of milk protein, major milk proteins, they were negative, and the casein was positive. Uh,
Yeah.
and
Well, we'll
yeah,
come to this.
so
1 second. So
yeah,
generally, as you rightly said, casein and
whey proteins.
whey proteins,
Yeah,
correct. These are
yeah,
the major proteins of the milk which are allergenic. And it's also important to know which component of the milk could be the causative factor. Again, going forward to the component testing, next slide, Dr. Vaidehi. There are specific indications in the context of food allergies where we would encourage doing component resolved diagnostic. This is not to be done as a first line testing in their diagnosis of food allergies. So especially if we have had patients with anaphylaxis, we are not sure what is the causative factor. If I have to know the persistence or the outgrowing of food allergies to prognosticate. Third, to know the cross reactivity of possible food allergens and pollens in the context of oral allergy syndrome. I think these are the 3 specific indications where we would do a component testing. Again, if possible, do a single food protein
short CRD,
yeah,
short CRD for a
yeah,
specific
single plex or
protein.
a specific food component testing, rather than doing a whole panel of component testing, which is quite expensive and may not change the management of the
Management.
child.
Right.
So I assume that you did this in the context that
Yes,
whether
yes.
the child is able
To
to
see the
outgrow, outgrowing of the milk allergy. What is the natural history of cow's milk protein allergy or egg allergies, Dr. Vaidehi?
natural history, if we consider, ma'am, 70 to 80% will outgrow by the age of 5 to 6 years. But doing CRD will help us to understand what is the probability of this child outgrowing that at that particular age. Because if we have BOSD8, that is casein component being highly, positive on the report, because casein is a heat stable protein, it's very, very resistant to heat. So the child may not tolerate raw milk items as well as baked food items, and the likelihood of outgrowing is also very low. So that's why to prognosticate this test would help. Whereas if any child has only whey proteins, that is BOSD4 and BOSD5 being positive, and casein is very low or negative, then the child, because these proteins are heat labile, they
Okay.
will get destroyed after baking or processing, and the child might
Not
tolerate
destroyed,
baked product.
it becomes modified in
Altered,
a way
yeah,
that the
modified.
protein is modified in that there is structural, so there is something called epitope conformational changes
Conformational and
happen.
sequential.
So yes, the protein by itself, they are the structural configuration undergoes a change, as you rightly said, on heating or baking, as you were telling in your earlier part of the presentation, where the child was able to eat certain well-cooked biscuits or in some well-cooked forms, where otherwise the child couldn't eat the dairy products in not so well-cooked forms such as curds or paneer otherwise. So that is the change which undergoes, as you rightly said, on cooking at higher temperatures by hydrolyzation or heating processes. So here also the slide shows that there is very good cross-reactivity between other sources of
Milk.
mammalian. Go ahead and finish your
Yeah.
case, Dr.
Yeah.
Vaidhi.
Uh,
No, next slide, please. Yeah, only with
yeah.
milk, any component was positive?
This BOSD6, which is serum albumin and also present in cattle meat, was also positive. That is because of the cross-reactivity.
Your casein BOSD8 or BOSD5?
BOSD8 was positive,
Yeah,
and also whey proteins were positive
correct. So
in this
BOSD8
patient.
casein is, as you rightly said, the chances that the child may take a little longer time to outgrow this milk allergy is very common. Okay,
Very
you're
common.
concluding slides, Dr. Vaidhi.
Yeah, yeah. So this diagnosis wise, this child has a IgE mediated cow milk allergy with asthma, allergic rhinitis, and malnutrition. Management wise, before going ahead with the test, we had to first stabilize her asthma part. She was prescribed low dose inhaled budesonide 100 microgram 1 puff twice a day as a controller, along with salbutamol as 3 to 4 puffs of 100 microgram to be given SOS for any flare up. And also for nasal symptoms, she was started on a mometasone nasal spray low dose, one spray in each nostril once before, like once night time for 1 month to stabilize her nasal and chest symptoms. For 3 months, the child was under good symptom control. Then on their own, they started tapering inhaled steroids. So she started having again frequent flare-ups since then. And again, she had one more admission. Then after that, she was again put back to little higher dose of inhaled steroids. After that, again this year, because after 1 year it was planned. So again, these things were repeated. The workup was repeated, but she is on the same line. The milk is still 5/5, and surprisingly, she is not positive for house dust mite despite having chest and nasal symptoms. And CRD wise, again, these things are equally positive. Rather, BOSD8 is still high, 9.96. And also, her indoor allergens were done. So, indoor allergen wise, she is not positive to any of the indoor allergens like cockroach or molds or house dust mite as well. So, she is
So,
still on the same level
okay.
with her milk allergy.
So again, it's my personal perspective, Dr. Vaidehi. I may be wrong, but I think what I would do is I wouldn't be repeating a component testing for this child, say after 1 year or after 2 years, because that is not going to change. This I'm talking in the context of food allergies. Okay, so we know that she is highly sensitized to the components of the casein component, which possibly the child wouldn't be outgrowing anytime sooner. I would wait until the child is a little older and probably see if at certain point I would start introducing milk in some form, because rather than the conventional teaching methods, which has been that complete avoidance has to be the norm, there has been a recent change in the school of thought that possible introduction in some forms can possibly augment the immune response towards outgrowing. Okay, so that's where the milk ladder and what we were talking about, the modification of the protein in well cooked or extensively hydrolyzed forms can tolerate, the child would be able to be exposed to the milk protein in some form by itself, which may not cause her full-blown allergic reactions. And that's where the milk ladder concept would come into concept. So I would refrain from doing a the component
CRD again.
testing, CRD every year. Probably skin prick test may not be, or the serum specific IgE again may not be a very predictive marker about the possible outgrowing. But I think that would help our decision about the introduction of the milk ladder, because that would be still positive or shows the sensitization pattern, what we call. So I would refrain from doing a component testing each year. Okay. So
Okay.
that is one
Okay.
thing what I may have done differently. Otherwise, I
Okay.
agree with your other aspects of management. Okay.
Okay. Okay.
I think you had a couple of slides on the milk ladder, Dr. Vaidehi.
Yeah. Ma'am, this was already, she was taught about
Yeah.
avoiding things and then reading food labels and carry the adrenaline injections, and action plan was given. Um, so natural history, these were a few slides about risk factors and natural history. We have already discussed all these things. So on the milk ladder, ma'am, the principle is same. We in the milk ladder, we try to give food protein in a baked form, so that the child develops tolerance to the raw form of the milk. So that is the main principle, and there are different steps. So in the Indian milk ladder, there are total 6 steps, where we start with a very small amount of milk protein in a cooked form, baked form, and gradually we increase the amount of protein, and also the cooking time is reduced. We As we go high, we go on to more and more of uh, the cooking time is reduced, and the amount of protein that we are introducing is more, and we keep assessing the child for the occurrence of reactions. And
Okay.
the guidelines are given, and the recipes for this are actually
Correct.
given. So the mother has to follow the exact recipe and
Correct.
has to introduce this. Especially this holds true for the children having non-IgE mediated food allergy. For IgE mediated, if there are certain conditions, like the child should be at least more than 6 years of age, where the child on encounter will be able to voice out the symptoms if the child develops symptoms after encounter. Second, there should be no recent history of anaphylaxis to the milk product or the food allergen.
Yeah.
And also the child should be able to should like the I mean, he likes the food item, and he is willing to consume that later on also after introduction of the
Yes.
milk in this manner.
Yes, I think the milk ladder, which we used to traditionally follow, the Western milk ladder, which was not very convenient for our commonly indigenously available resources. I think Indian milk ladder definitely gives us customized, indigenously available, locally sourced material, which we can definitely incorporate in our weaning foods or the child's diet, which could definitely augment the outgrowing of milk ladder. I think um, Dr. Vaidehi, thank you for an excellent case presentation and bringing out the nuances about the most commonest food allergy we see in infants, that is cow's milk protein allergy. I think I would give some take-home messages that all mothers should be educated that breast milk is the best nutrition source for their infants, and um, this is the most commonest number one food allergy we see in infants, and we should continue uh, breastfeeding in children with cow's milk protein allergy also without any restriction of the uh, dairy or dairy products in the mother. If you are have to give specific indications, be very clear, and when you have to start possible formulas, be very clear why would you have to do it, and always uh, uh, try to incorporate the milk ladder wherever feasible. So again, thank you, Dr. Vedi, for an excellent presentation, and thank you for the opportunity.
Thank you, ma'am.
Yes. Thank you, Dr. Soumya, for that excellent, you know, moderating the session, and thank you, Dr. Vaidehi, for such an excellent case presentation. We had a lot of learning points in this session, and I'm sure the participants would have benefited a lot. And I don't think there are any questions. I think we mostly discussed most of them as we were going through the case. So, shall we wind off then, ma'am?
Yes, Dr. Sinchana. Thank you.
Thank you.